So I am very excited to introduce my colleague, Dr. Begi Baran. Begi is a neuroscientist. She received her PhD in psychology from the University of Massachusetts Amherst. There she studied the effects of aging on sleep-dependent memory consolidation. She then completed postdoc training in sleep, circadian, and respiratory neurobiology at Harvard Medical School. She joined the faculty here at the University of Iowa in the Department of Psychological and Brain Sciences in August of 2020. But prior to that, she was on the research faculty at Massachusetts General Hospital. Begi is interested in understanding the role of sleep in the etiology of psychiatric disorders, and she has a specific focus on identifying sleep-related biomarkers of risk for psychotic disorders. And here she uses neuroimaging techniques like fMRI and sleep EEG. Dr. Baran's work is funded by the NIMH, the Iowa Neuroscience Institute, and through donor funding. She serves as the Director of Neuroscience Research of the Psychosis Risk Intervention, Education, and Research, or PEER program. And this is a research and clinical program that aims to enhance our understanding of at-risk mental states. So I am very happy to introduce Begi, and I'll let her take it away.
Thank you so much, Amanda. The luxury of being introduced by a close collaborator is that you've already gone through some of my slides, so it just makes it much easier for me to use my time. So I'm very excited to be here to talk about something very near and dear to my heart, which is the importance of sleep for mental health. Okay. So just as Amanda mentioned, I direct NAP Lab at the University of Iowa, where we study the causal role of sleep in the emergence of mental illness. And I'm really most interested in how psychotic disorders emerge and what sleep can tell us about the clinical high risk for psychotic disorders. I also co-direct the PEER program with Amanda, which is the newly established psychosis high-risk program. And I'll tell you more about the sleep-related goals of the research aspect of our PEER program in a little bit. So before I delve into the links between sleep and mental health, let me just start with sharing with you why I'm so interested in studying sleep. And the reason is sleep is not like a static, unchanging behavior. Rather, it keeps evolving throughout the night and also throughout our developmental lifespan. You may have heard about the distinction, for instance, between rapid eye movement REM sleep and non-REM sleep. So let me tell you more about different sleep stages. So what I have here is what we call a hypnogram, which shows us how we move from one sleep stage to another throughout the night. And you can see there's quite a bit of ups and downs that we go through as the night progresses. On the right side of the hypnogram, I have little tiny snippets of how the brain waves look like in each sleep stage. And you can see that they're quite different, right? What the brain exhibits in terms of potentials is quite different across REM sleep and non-REM sleep. What's also more fascinating is that these different sleep stages are associated with quite different, quite distinct brain states, such that concentrations of brain chemicals, neurotransmitters, change across different sleep stages. So does the direction of communication between different brain structures. Which brain structure sends what type of information to another evolves, changes throughout the night. So in other words, we might be sound asleep, we might be resting, but simultaneously our brains are going to be very busy processing what we have experienced throughout the day, identifying overall themes, for instance, with respect to emotions, and also categorizing new learning with respect to our already existing knowledge databases. So quite a lot of work. So this all sounds great. I made it sound like we as sleep scientists know exactly what sleep is for, but the truth is we don't. We have no straightforward answer, for instance, for why we sleep. Come to think of it, it comes down to approximately a third of our lives that we as humans spend asleep. And it's quite a big commitment for an organism to take itself offline for such a long time throughout its lifespan. right? With respect to evolution, we don't quite know why sleep emerged in the first place. And related to these deep philosophical questions, we can't quite answer the question with full certainty as to whether sleep is essential for our survival or not. So going a little back to evolution, here's a curious observation. Take a lion, for instance. They sleep on average 16 to 20 hours a day. And these guys are, you can see, sleeping out in the open in the savannah, like they have no care in the world, right? Antelopes, who emerged right around the same time in evolution of vertebrates, can only sleep up to 4 hours, and that's on a good day. And their arousal mechanisms is built such that they're awakened immediately by the sign of danger. So we could conclude that sleep duration is partially determined by prey status. Those who can ensure their safety, in turn, can afford to sleep more. But that's not just that variable of being a prey or predator, because not all of the super sleepers are predators. It also has quite a lot to do with metabolic rate, for instance. Those animals with faster metabolisms need to sleep more so that they can balance their energy expenditures. So just in short, although we don't have a definitive answer, the amount of sleep has something to do with how a species achieves its biological goals of first survival and second procreation. And here's another curious example. Marine mammals, dolphins, for instance, they have to go up to the surface quite regularly to breathe, right? And as an adaptation to this problem, their brains came up with a very unique solution. Their brains sleep 1/2 at a time. So while 1/2 of the brain is resting, the other half is working such that the fin that's controlled by the other side of the brain moves all the way up to the surface so that the animal can breathe and move on. So the fascinating animal kingdom aside, I just wanted a good excuse to put up cute pictures of animals to keep your attention with me. One of the functions of sleep that we now have strong scientific evidence is that sleep is critical for cognitive function and also for emotional processing. Sleep helps strengthen and consolidate our memories. It helps keep our attention at higher function. It also helps with how we regulate our emotions. And this is still an emerging and a very active line of investigation. The very first findings that sleep improves cognitive functioning came out about only 20 years ago. And since then, it's been a skyrocketing increase in the amount of work published on this. And this is covered not just by scientific outlets, but also by popular science outlets as well. So let me just give a full spoiler of the kind of work that I'm involved in before I move any further. With both clinical observation, we could ask patients, we could ask caregivers, we could ask doctors, and also in terms of large-scale epidemiological studies, we know that abnormal sleep is a core feature for several psychiatric disorders. Sleep disturbance is listed as a diagnostic criterion for several disorders in DSM-5, for instance. That includes major depression, generalized anxiety disorder, bipolar disorder, just to name a few. But the problem with all of these is that sleep disturbance is very broadly defined, and how it relates to mental illness is rarely known, which is a missed opportunity, because if we understand how sleep contributes to mental illness, then maybe we could get one step closer to coming up with effective prevention or treatment strategies. So in a nutshell, I'm sorry. So in a nutshell, we know that sleep disturbance precedes and even precipitates most major psychiatric disorders. We also know that sleep is critical for cognition and emotion. So I argue that some, if not most, of the cognitive impairment and emotional regulation deficits in mental illness are sleep dependent. So the goal of my research is to identify the precise abnormality, precisely what's wrong with sleep. So in other words, let's say it's not just called a sleep disturbance. Let's try to understand what that disturbance is and try to come up with an explanation as to why that sleep disturbance may cause cognitive and emotional impairment, so that we can determine if we can provide a treatment target based on that sleep disturbance. So how do we do this? We start with a disorder where we know sleep disturbances and cognitive or emotional regulation deficits have been reported. Next, we try to identify exactly what these sleep disturbances are. Then we try to relate the sleep disturbance to cognitive and emotional regulation abilities, and also to symptoms of that disorder. And then go deep into the neural circuitry involved in that feature of sleep and see whether those brain circuitry are intact, or there's some abnormality that we can detect in this disorder. And we do this by using both, using several brain imaging methods. So the ultimate goal is, as I said, is to provide a mechanistic explanation of the role of sleep in mental illness, and to possibly devise clinical trials that will target that sleep disturbance. And as I said, we use several fancy tools to try to answer these questions. Speaking of tools, how do we measure sleep? Right? When we go into this, there's two primary variables that are important. One of them is feasibility. How easy is it to collect data about sleep? And the second is validity. Am I actually measuring sleep objectively and in a repeatable way? So high up in terms of feasibility are things like self-report. And by self-report, I mean sleep diaries, for instance, where you ask people what time they went to bed, what time they woke up, what their sleep quality was, how long it took them to fall asleep, etc. This is extremely easy, right? I can reach thousands of people at a time with these questions and collect large amounts of data. But the problem is, it's not going to be very accurate, very representative of the underlying construct. The reason is, us human beings, we're really bad at coming up with valid and objective evaluations of our own sleep. It's known that we all overestimate how long it took us to fall asleep. We also all underestimate how much we slept. And there's also some individuals who might have cognitive deficits or other issues that might not allow them to do these self-reports, or babies, for instance, who would just not be able to do that. So going down on the ladder of feasibility are device-based measurements. And by device-based, I mean wearable technologies. There's just so many of these commercially available products that offer to monitor your sleep and give you detailed reports of how well you slept. And I usually get asked the question of whether I recommend a particular brand or not. And my simple answer is, I don't know, because these are made by consumer-facing companies, and these are made for profit, right? And the whatever detection method they use to detect and evaluate sleep, that's usually, well, almost never shared with researchers or shared with the broader community. So we have no way of comparing what the evaluation of the wearable technologies is of sleep and what the actual sleep is. At least ourselves. I'm sure they do their own due diligence in terms of validation. It's just not something available to us. In contrast, these highly unattractive devices called actigraphy watches are designed specifically for research purposes. They are able to detect changes in movements continuously throughout the day, across several days. several of them come with features like light detectors, for instance. It can tell how much light exposure a person has. So what's nice about these is that they're really open in terms of what kind of detection methods they use for recording movement. So because we're continuously monitoring how much a person is moving throughout the day, we infer from lack of movement that the person is asleep. So here are a few problems with that. For instance, I study severe mental illness, and patients might be more likely than another person to be more sedentary, right? I have no way of telling if a person is lying in front of the couch watching Netflix or if they're sleeping with just this watch. Same goes for whether a person is ironing or if they're really engaging in strenuous physical activity. So I get some objectivity with these devices, but again, I'm not getting good in terms of validity. So very low on the feasibility end is in-lab monitoring of sleep with what we call polysomnography. It's very low in feasibility because a person has to physically drop everything off and has to come to the lab for us to monitor their sleep. And it also requires, the lab is staffed by specialized trained technicians who can record that kind of data, which is actually what we do in my lab. This is one of our junior scientists posing for the camera with the device that we have. We use a cap which has special sensors that can identify brain waves while we're sleeping. So we're getting really accurate in terms of monitoring sleep, and we get quite a bit of specificity in terms of which parts of the brain I'm monitoring and what kind of brain activity I can see. And mind you, all of these things are done with this tiny, tiny device, which doesn't even need to be hardwired to a computer. It can record on itself, and it also has Bluetooth connection. This is a long ways that we came in terms of sleep research to these EEG recorders of the 50s and 60s, which had to physically write to a piece of paper with the pens. And it was a huge machine that had to keep recording the EEG activity. So let's switch gears a little bit and talk about the role of sleep in development. Sleep does play a very crucial role in development. And accordingly, as a sign of this, sleep changes quite a bit in terms of not just its duration, but also its physiological makeup. So duration-wise, let's look at this plot, which shows sleep duration and also makeup of sleep across different stages, all the way from 5 years of age to 85. You can see that duration changes quite a bit. A 5-year-old requires around 10 hours of sleep, which is going down as we get older. Things like wake after sleep onset, how much we have to get up and go around in the house after we fall asleep, that also changes. It increases as we get older. So does sleep latency, time it takes us to fall asleep, that also increases with age. And the duration of rapid eye movement to the ratio of rapid eye movement sleep to non-rapid eye movement sleep, that also changes quite a bit with development. So let me just very briefly walk you through different life stages. We all know that sleep in infancy is all over the place, right? A newborn is going to sleep all throughout the night and day, or feed throughout the night and day. But there's a great deal of individual variability in terms of these patterns and how these are established. So take the example of these two different infant babies, and we will track them for the first 2 months of their life. The black bars here are when the infant is awake, and the white bars are when they're asleep. So you can see the first few weeks, it's all a blur, right? They will be sleeping pretty randomly. But with this infant on the left, there seems to be a pattern that emerges very early onward, as early as the first 2 months, that the baby prefers to be more active during the day and prefers to be more asleep throughout the night. On the contrary, with this other infant, that pattern is not established quite a bit, even after the first year or first year and a half of life. How about early childhood? So these are just pictures of cute little monsters making a run for it out of their beds to their parents' rooms, or waking up screaming in the middle of the night, which are quite commonly observed behaviors in toddlers and young children, right? But let's keep in mind that early childhood is a period of very important, very critical developmental milestones. And the child reaching some of these milestones in turn influences or is reflected in their sleep behavior. So let me just try to unpack some of these a little bit. Reactive co-sleeping, making a run for it for the parent's bedroom, is a byproduct of the fact that the toddler is now able to move more independently, is a byproduct of increased independent locomotion. Right? Same goes for nighttime fears or the insistence on transitional objects like fuzzy teddy bears. They're just showing that the baby, the child, is showing cognitive development. It is now capable of fearing something. Similarly, frequent night awakenings is a sign of the emergence of attachment and also a sign of healthy separation anxiety. Bedtime resistance is driven by the child's drive for autonomy. When we get into middle childhood, children generally keep their habitual sleep duration in the first decade of life at a similar relative position, which means that if a child is a crappy sleeper at age 3, chances are it's going to stay a crappy sleeper at age 7. Children also start to manifest as morning or evening times. So what I'm talking about here is things like being more of a night owl versus more of an early bird. And that's why determining the optimal bedtime for children at this age is quite not possible. There is no golden rule of a child should go to bed at this particular hour. So moving on, I'm most interested in the transition from childhood to young adulthood, the adolescence period, because actually this is the time when individuals may start exhibiting early signs of mental illness. And the issue here is that adolescent sleep is typically considered a perfect storm. And let me just tell you why. Their brains are going through a very rapid phase of maturation. And as a byproduct of this brain maturation, their sleep pressure decreases. In other words, their brains get much better at resisting the urge to fall asleep. Think of a 9-year-old who's very likely to fall asleep in the car seat or in front of the TV. Right? How about a 12-year-old? Not so much. Their biological clocks also go through a maturational phase, such that biologically, they are wanting to go to bed later, and they're also wanting to wake up at a later time. So it's just biology pushing them strongly towards the direction of a delay in sleep time. This is actually further strengthened by psychosocial pressure, which is also pushing in the same direction. So what is that? They have more school-related, they have more curricular activities. They also have more extracurricular activities. They start part-time jobs. They want to spend more time outside with friends or at home with their friends on social media, right? So all of these things are pushing them towards a delay in bedtime. But on the contrary, there is societal pressure for early rise in the sense that high school start times across the board in this country are earlier than elementary school or middle school start times. Iowa, compared to several other states, is in a quite better position. Still, there's a push for earlier, not for later, to match their biology or their psychosocial makeup, right? So this opposing pressures in these different directions results in a very bad consequence, unfortunately, which is that they're not able to get the much needed sleep. But what happens when a person is not able to get enough sleep as an adolescent? There's several negative outcomes associated with it. Mood disturbances, attention deficits, issues with their immune system, metabolic problems like the increase in obesity has been associated with shorter sleep durations in adolescents. Also things like traffic accidents, substance use or misuse of medications, over-reliance on caffeinated products. But it's not a very grim picture that I'm trying to paint here. There's quite a bit that can be done and is being done. First off, we need more and targeted research on the importance of sleep in adolescents, right? That helps with advocating for change in school start times and trying to limit late evening activities, which are sometimes forced upon the adolescent. More education about sleep hygiene and also empowerment of adolescents in terms of making healthy decisions about their sleep. We also need to give more guidance to parents in terms of how much support they can give to structuring the schedule of the adolescent. And perhaps much importantly and much overlooked is that we really should be maximizing the beneficial effects of light in adolescents, not just in adolescents, all of us, but particularly in this age group. If we can help them make as much use of daylight during the day as possible, keep some of the activities in very well-lit rooms with natural light, of course, or even outdoors, that helps quite a bit. What also goes a long way is making sure that in the evenings, they're not in highly lit environments and they're trying to stay away from screens as much as possible. How about older adulthood? With older age, daytime naps increase. It's about 10% of adults ages 55 to 65 that say that report napping daily, and it goes all the way up to 25% in the 75 to 85% age range, which is quite high. And many of these naps are unplanned, and they could be a byproduct of the fact that they may not be getting good quality sleep at night. That could be a compensatory mechanism. As a result of this, many older individuals feel dissatisfied with their sleep. Sleep also tends to be shallow, more fragmented, and variable in duration in both middle-aged and older-aged adults compared to young adults. So I showed you I showed you what a hypnogram is. That was for a typical healthy young adult, right? This is what a hypnogram usually looks like for an older individual, as opposed to good undisturbed chunks of different sleep stages that we see in young adults. They seem to go in and out of different sleep stages quite often. There's also more time spent awake throughout the night compared to a young adult. And some of these have to do with comorbid disorders, having to use the bathroom quite often at night, or with some of the medications they're taking. But some of these are quite addressable in terms of public health point of view. Okay. Now that I've gone through a very comprehensive introduction on sleep, maybe more than you would need, let me talk about the emerging field on the role of sleep in mental health, which is why we're here for, right? Historically, sleep disturbances used to be seen as a consequence of mental illness, but now we know that these are truly bidirectional relationships. For instance, there is now growing evidence that poor sleep may induce or even exacerbate depression. Similarly, there's also a striking link between sleep and symptoms of anxiety, such that things like worry and fear contribute to a state of hypervigilance and hyperarousal, which makes it much harder for the individual to initiate or maintain sleep. And the end result, sleep loss, further amplifies a person's emotional reactivity. And since I've introduced this vicious loop, let me just try to unpack this with some experimental evidence. I won't go into the science of it too much, the methods of it too much, but I'll just give you a flavor of what experiments are being done currently on this. Sleep loss is shown to alter how the brain responds to emotional events. So in this particular experiment that I will briefly talk about, the authors focus on anticipation. So anticipation is an adaptive process. It mobilizes our preparatory responses to impending threat or danger, right? So it's a good thing. However, in excess, anticipation can be quite maladaptive. It can contribute to rumination and symptoms of worry. So this is a very simple experimental task. What they did was they showed individuals some gruesome pictures, like a person pointing a gun at you, or some very neutral pictures, like a doorknob, for instance. And all of these were happening while the person was inside an MRI scanner, which is able to record the brain responses as the person is seeing these images, right? So before these images emerged, in some cases, there was a cue for quite a bit of time that came up on the screen, which would say something gruesome is going to come up. In other cases, there was a sign which clearly said something neutral is going to come up. But in other cases, it was an uncertainty signal. That was just a question mark. So the person had no idea whether something gruesome or something neutral is going to come up. And individuals, and these were healthy young adults with no prior history of any mental illness or no heightened or clinically meaningful depression or anxiety levels, who participated in this experiment. And they did this task twice, once after a healthy, regular, typical night of sleep, and once after 24 hours of sleep deprivation. And to try to make the sleep deprivation condition as least stressful as possible, they made sure that an experimenter is engaging with the participant throughout the night. They're just playing some boring tasks like card games, computer games, etc. So as I said, brain responses to these uncertain, these ambiguous cues were recorded twice, after sleep deprivation or after sleep. They also identified two brain regions as critical for emotional processing. And here's what they found. They found that sleep deprivation amplifies brain's preemptive responding during the anticipation of potentially aversive experiences. So these brain regions were lighting up, were being active way too much after sleep deprivation compared to a healthy night of sleep. And also, even though everybody was within normal levels of trait levels of depression or anxiety, those with higher trait anxiety levels demonstrated the greatest vulnerability to the amplifying anticipatory effects of sleep deprivation, which was reflected by largest increases in brain activation in these structures. So the take-home message here is that even with a single, just one night of sleep deprivation, we see a change, a profound alteration in how the brain responds to anxiety, how the brain responds to uncertainty. And the effects of this anxiety building effects of sleep deprivation is more amplified in those who start out with higher levels of trait anxiety, even if it's in within normal levels. So a related question is, what do we know about the anxiety generating impact of sleep loss, right? So let me just briefly talk about another experiment. Again, I will not go into the methodological details of it. Suffice it to say that, again, healthy young adults went through either a night of typical normal sleep or 24 hours of sleep deprivation. And each person did both of the conditions. And they were asked to rate their anxiety symptoms throughout the same time points, before, in the evening, and also in the morning. Also in the morning, they again went through a brain scan in which they were shown either very negative, very aversive videos or very neutral videos. And their brain activation patterns were recorded in response to these movie clips. So here's what they found. Not surprisingly, of course, individuals reported higher levels of anxiety the morning of sleep deprivation compared to a healthy night of sleep. So, right, that's what's expected. But also the brain regions, which are responsible for generating emotional responses, the brain regions that make you fear something or that make you any of the positive or negative emotions, these emotion generating brain structures were showing much stronger, much higher activation during aversive movie clips after sleep deprivation compared to a night of sleep. In contrast, the brain regions, which are on the front part of our brain, which are responsible for emotional control, emotional regulation, they were showing weaker activation after a sleep deprivation. And that these two processes were quite related with each other, meaning that the weaker the person's emotional control after sleep deprivation meant, in turn, the emotion generating centers of the brain were showing more amplified responses, stronger responses to negative stimuli. So it's not all bad news, though. As I said, they have a sleep deprivation condition, but they also had a healthy typical night of sleep condition. That way, they were able to look into what's about sleep that may be associated with emotional responses. Right? What they found was that, again, I'm going back to my hypnogram, individuals who showed greater levels of deeper stages of sleep, they expressed greater evening to morning dissipation of anxiety after sleep and a lower next day anxiety levels. Also, after a night of sleep, the emotion control regions of the brain, the frontal parts of the brain, would show stronger activation in response to negative movie clips. So the brain was better equipped after a night of sleep in terms of regulating our emotions. And this stronger activation of the emotional control regions was in turn associated with significantly lower next day anxiety. So, in summary, even a single night of sleep loss changes how our brains respond to negative stimuli. But deep sleep, slow wave sleep, helps protect our emotion regulation abilities, right? So this is what we should be hanging on to. So not to muddy the waters here, but I want to highlight that these are not straightforward effects, and that we still have a very long way to understand the very complicated nature of relationship between sleep and mental health. For instance, as it relates to mood disorders. You might have heard about wake therapy for depression. In contrast to all that I've been telling you about the negative consequences of sleep loss, sleep deprivation can produce some therapeutic effects for depression. This is something that came up more than 50 years ago, and it was entirely based on clinical observation or anecdotal reports of some patients treating their own depression by depriving themselves of sleep. And since then, thousands of patients have been treated with this quite controversial antidepressant technique. The rapid antidepressant effects of sleep deprivation, I'm saying rapid because after a night of sleep deprivation, a person can experience alleviation of their depression symptoms. This rapid antidepressant effects is highly reproducible and it's quite substantial, but this has never been considered a first line of treatment for depression. And the primary reason is that this antidepressant effect is very transient. Most patients show a relapse after a night of recovery sleep, even if they were showing a complete response after sleep deprivation. So they might be feeling really good as they're in the sleep deprived state, but once they catch up on their sleep, depression symptoms come back again. And obviously, it's just not sustainable for us to sleep deprive ourselves indefinitely, right? We all have to sleep eventually. There are so many unknowns about sleep deprivation therapy for depression. For instance, it is unclear how many hours of sleep deprivation we need to achieve its full antidepressant effects. As I said, because it's not sustainable to stay awake several days in a row, there have been several variants. For instance, depriving a person of only REM sleep or partial sleep deprivation, in which sleep is allowed during one half of the night. But which half? We're not quite sure. Clinicians typically suggest the first half of the night, but there's no clear evidence as to which half. But as I said, it's the response, the antidepressant response is quite substantial, and it's really similar to antidepressant drugs. It ranges from 50 all the way up to 80% in some reports. And also patients' sleep characteristics prior to their sleep deprivation may influence what kind of response they give to sleep deprivation. And I hope I'm making it clear that we still have no idea how this works. And the thing is, it can go wrong, particularly if we think of high-risk situations. For instance, individuals with bipolar disorders, sleep deprivation, sleep loss, triggers manic or depressive episodes, may make their clinical presentation much worse. It's also highly risky in terms of individuals who are already at high suicide risk. Sleep deprivation might amplify suicidal ideations and behaviors. I also want to highlight that this should not be taken as by any means as support for disturbing sleep in individuals with psychiatric disorders. A major problem in psychiatric wards and hospitals is sleep deprivation or the sleeping environment, because hospital alarms go off, the nursing staff or the residents come into the person's room across random times of the day and night to check in on them. They wake them up for vitals, etc. Right? And this is a major problem that we really should be working to try to keep their sleep environment as healthy as possible. There's one thing. I have a colleague back from Boston who's been quite interested in sleep deprivation therapy for depression, and she even got a major funding to start working on this. But I know that as soon as she started this major project, COVID hit, and that quite interfered with how her work was progressing. So I'm really on my toes watching to see what comes up of a really intelligent and thoughtful design of trying to understand wake therapy for depression. And I hope that might guide us in terms of coming up with better treatment strategies. So moving on, bipolar disorder. Changing sleep in this case is a diagnostic feature that change in sleeping patterns defines some clinical features of bipolar disorder. Also, stabilizing a person's sleep-wake patterns is recognized as therapeutic and is regarded as part of the consensus treatment guidelines for bipolar. Sleep disturbance is the most common prodrome of mania, meaning that the less reliance, the less need for sleep might be a sign that a manic episode is coming up, and it's also a significant prodromal symptom of bipolar depression. Altered sleep often predicts deterioration of clinical state, but as I was trying to allude to at the beginning, despite this really well-recognized relationship between sleep disturbance, symptoms, and relapse in bipolar disorder, our understanding of the exact nature of sleep deficits is still very limited. And this is something that my lab is actively working on. So I will say stay tuned. Our ongoing work is focused on characterization of brain waves during sleep in bipolar disorders. And we're trying to relate these brain waves during sleep with cognitive function, with clinical symptoms, and also with the integrity of brain circuitry that propagates these brain waves. And this is the work of a very highly skilled and motivated junior researcher in my lab, Gonzalo Quinones, who's tackling this question as part of Iowa Neuroscience Institute's research programs of excellence. So moving on, schizophrenia. Psychotic disorders are best recognized by the fluoride positive symptoms or negative symptoms, but cognitive deficits are a core feature of schizophrenia. This is at the heart of a lot of my research and also Dr. McCleary's research. And our work in the past 10 years back in Boston has shown that some of the cognitive deficits that we observe in patients is actually sleep dependent. With schizophrenia, the case is that when you look at the hypnogram, the overall architecture, duration, and sleep stage makeup of sleep in schizophrenia, at least those with established disorder, with a chronic schizophrenia, there's no differences that can discriminate an individual with schizophrenia from an otherwise healthy typical individual. But there's one specific change that we detect with their sleep, and this relates to a brain wave that we exhibit during non-rapid eye movement sleep. This waveform is called sleep spindles because of its waxing and waning structures. And I won't go into the details of it, but when we use polysomnography, the cap that I showed you a picture of, and we record brain waves throughout the night and detect these waveforms and compare it between patient and control groups, what we see is a profound reduction in those with schizophrenia. They're not able to generate this waveform as well as healthy controls. And that actually correlates with cognitive deficits. The less the person is able to exhibit this particular waveform, the less of a sleep benefit a person can get from their sleep. This finding is quite well replicated across different labs. And also, it's not due to the fact that this is a chronic disease or because of a variety of medications that those with schizophrenia have to take. For instance, this is based on archival data, but we just replicated the same finding that the change in this waveform, the change in sleep spindles, is also seen in early course patients. This is a night of recording after a first psychotic episode. And although as a group, the early course psychosis patients show this reduction, it's only those who later go on to develop schizophrenia that actually have this reduction in this particular sleep wave. It's not just the patients per se, but their young, non-psychotic first-degree relatives also might show reductions. These relatives are also at a higher risk for exhibiting cognitive deficits. And there's the link between the reduction in sleep spindles and also their cognitive impairments. So overall, this kind of work that I've been involved in the past, for the past 10 years, shows that sleep spindle deficits, this particular waveform, is a putative marker of schizophrenia, marker of whether a person has schizophrenia or not. It predates its onset. It persists throughout the course. We see it in early course. We also see it in chronic patients. It's not related to any particular drug that you're using. They're also present in first-degree relatives, suggesting that there's a shared genetic component to it. It's also importantly linked first to cognitive function, and also second to their symptoms, particularly the degree of positive symptoms. So at this point, what I'm most interested in is to understand whether these sleep abnormalities are evident in those who are at heightened clinical risk. And that's where things like our peer program come at a very much needed place in terms of research and our understanding. As you may have heard, at various occasions, Amanda and I have just launched the peer program, the Psychosis Risk Intervention Education and Research Program. With this program, we're able to offer free risk assessment to individuals who might be experiencing unusual changes in their mood, their thoughts, their perception, and their behavior. As part of it, we are able to provide a free clinical research-based evaluation, both to detect whether the person is in clinical high risk or not, but also for longitudinal monitoring of the person who might be at risk, at clinical high risk for a psychotic disorder. We're also able to provide psychiatric referrals to UIHC hospitals. We also provide them with opportunities to participate in research studies. We're trying to give psychoeducation devised both for the family and also the individuals. So as part of the peer program, though, my research goal is to be able to accurately identify those who are at clinical high risk for psychotic disorders and track their sleep and their brain, the integrity of their brain circuitry longitudinally, to identify sleep-related markers that might alter their developmental trajectory and might result in the emergence of, or the conversion to psychotic illness. So I know we're running low on time, so I'll just very briefly talk a little bit about insomnia and try to end with some suggestions about sleep health. Insomnia is the second most commonly expressed complaint in clinical settings. The first is pain. It may include complaints of an inability to fall asleep and inability to maintain sleep, or experiencing frequent early morning awakenings and without the ability to return to sleep. Patients often report that their sleep is quite unrefreshing. And sleep difficulty usually occurs in the context of adequate opportunities to sleep. So their lack of sleep is not because of lack of trying, but they're just not able to fall asleep. It's more common in women. It's also related to hormonal status because its prevalence peaks during pregnancy and also in menopausal years. It's also more common in adolescents and also older adults, which correspond to changes in a person's sleep pressures. They're also more common in shift workers than individuals working fixed schedules. So if I briefly talk about insomnia subtypes, there's a very umbrella term that calls it psychophysiological, which says it's the result of a maladaptive behavior during periods of stress. And it relates to all that I was telling you about in terms of sleep loss and anxiety and unhealthy brain responses in terms of ambiguity and anticipation, right? And what we typically talk about is a vicious cycle of increased concerns about sleep, trying harder and harder to fall asleep, which further increases the person's worry about the ability to fall asleep. The treatment includes behavioral interventions, things like cognitive behavioral therapy, specifically designed for insomnia, education about sleep hygiene, and also temporary pharmacotherapy. And I cannot stress the importance of temporary in this context because the medications that patients are typically prescribed for insomnia they alter the quality of sleep. The kind of sleep that you're getting with, for instance, Ambien is quite different than the makeup of sleep that you get naturally, right? So the goal of prescribing medications, sleep-inducing medications, is to try to break this vicious cycle that I was just telling you about, giving the individual the opportunity to use their body's own arousal lowering mechanisms and to induce sleep. Treatment for cognitive behavioral therapy for insomnia is as effective, if not more effective, than pharmacotherapy. And it includes three components. It includes cognitive interventions, for instance, cognitive restructuring to address a person's anxiety about not being able to fall asleep or the impact of daytime fatigue. It also includes behavioral interventions, for instance, relaxation training or stimulus control or sleep restriction. The idea is if the person is not able to fall asleep, they're recommended to not to toss and turn 4 hours at end in bed, but just to change the settings and try again. And psychoeducational interventions, which is providing objective information about sleep hygiene. Let me just end with some recommendations here. So, how much sleep do I need is a question that I get quite often. And it's such a loaded question and such a challenging question to answer because there's no right or wrong answer in terms of sleep. That's determined by whether you're an evening chronotype or a morning chronotype, whether you're a night owl or a morning lark, and what kind of job schedule, what kind of force schedule you have, what time do you have to wake up. And another thing is how much of sleep pressure you feel, because there's quite a bit of variability in terms of whether we tend to be long sleepers or short sleepers. But I always try to go to this table in terms of upper and lower ends of recommended sleep. So for adults between the ages 25 and 65, the recommended sleep duration is 7 to 9 hours. And it's what's considered, again, within normal, is usually anything between 6 to 10 hours, as long as the person is able to wake up refreshed after this much of sleep. But if they're getting less than 6 hours or more than 10 hours, the recommendation is to immediately seek medical care to see a sleep specialist. So some do's and don'ts of sleep hygiene. As I was telling you when we were talking about adolescents, it's very important to increase exposure to bright light during the day and to try to limit the exposure to screen lights, for instance, during the night. It is very important to establish a daily activity routine and to try to stay within that routine. It is very important to exercise regularly in the morning and or afternoon. And the reason I'm saying morning or afternoon is because if we engage in strenuous exercise within a few hours of our bedtime, that delays our body's ability to fall asleep. And the idea is typically our body temperature is lowered 1 to 2 degrees, which signals to the brain that actually it's time to fall asleep, and that triggers the sleep response, the sleep hormones, melatonin, to be secreted. If you're exercising strenuously close to bedtime, you're artificially increasing your body temperature, and that's messing up with the brain's ability to be able to signal that it's actually time for bed. Establishing a really comfortable sleep environment, doing something relaxing before bedtime, not watching the news, for instance, and trying a warm bath. Again, a warm bath is important because when we take a warm bath, we increase our body temperature during the bath and it decreases right after, right? So even if this decrease in body temperature is not happening naturally, you're telling your brain through the warm bath that you took that it's time to fall asleep. Don'ts of sleep hygiene: avoiding alcohol, especially in the PM. Most definitely avoiding caffeine, nicotine, or other stimulants, medication included, in the PM. Exposure to bright light or screen lights, blue lights during the night. Again, as I said, exercising within 3 hours of bedtime, heavy meals or drinking within 3 hours of bedtime, using your bed for anything other than sleep or sexual activity. No Netflix and chill in bed, please. That's really bad for us across many levels. Napping, unless that's a very typical thing for you, or unless you're a shift worker and you're trying to make up for lost sleep. Constantly watching the clock at night, seeing how I'm doing, am I asleep, why am I not asleep, right? Another thing is, if you already have some concerns about your sleep, I really would recommend not to use those wearable technologies. First, they may not be accurate. Second, that might increase our worry behavior in terms of our ability to fall asleep and to stay asleep. Also, excessive heat or cold in the room interferes with our ability to fall asleep. Okay, I am sorry I talked so much. I think I might be over time at this point. But just a quick plug-in. If you're interested in participating in our research, we have established Hawkeye Reconnect, Hawkeye Research Connection, to better match individuals who are interested in participating in research with the neuroscience research and the clinical psychology research available in our community. We have our webpage, which is Reconnect Psychology U Iowa. .edu. You can also use this QR code to get to the form that we use to reach out to research participants. If you're interested in the psychosis risk intervention education and research program, you could visit our website www.peer.uiowa.edu and fill out the contact form, or you could email us at pbs-peer@uiowa.edu or call us. If we go to our webpage, peer.uiowa, you will see that there's a complete form option, which takes you to a separate web page, which allows you to give information in terms of contact information, and also whether you're filling out the form on behalf of yourself or a loved one, or as a clinician if you're referring, or an educator you're referring the individual to us. All we need is the permission of the individual for us to contact them, so it does not come as a surprise to them. So that's all I had to say for today. Thank you so much for all your attention. And I'm here to answer any questions if I didn't already talk too much.